in my opinion, add it to the file of all the recordings that none of us are ever going to watch. I have a ton of them of webinars that I registered for inside COVID that I will probably never watch. So, ideally, you have pen and paper. What I'm going to suggest is that you draw a triangle on your pen and paper. Works best for this particular model if there are 2 points at the top and 1 point at the bottom of your triangle. And we're going to label the points sex, gender, and sexual identity or sexual orientation. Rebecca is showing the handout. It's a double-sided handout that some of you may have access to, some of you may have printed out, some of you may not have, and so I'm going to walk you through it just in case people don't have the handout handy. That was hard to say, handout handy. So top left corner of the triangle, we're going to start with sex, not the act of, that is a different workshop. So we're going to start with anatomy and biology. And so if, typically speaking, I would call out, and those of you who have access to the chat, you're welcome to put it in the chat, but what are sex-based characteristics of anatomy and biology? What are those things? So feel free to type them into the chat. If you would like to go rogue and say them out loud, you are also welcome to do that. But when we talk about anatomy and biology, what are sex-based characteristics? So genitalia always comes up first.
So vagina or uterus would be those that are consistent with the sex of female, and penis, testicles would be consistent with the sex of male, and intersex would be a combination therein.
Perfect. So that window is labeled lounge. So 2 points for the lounge, which is almost like going to Slytherin. So that's perfect. Right. So when we start talking about sex-based words, first off, using the word female and male are the sex-based words that we use in a very binary kind of way. That everything male is usually penis, testicle, sperm, testosterone, XY related. And everything female is usually vagina, uterus, estrogen, XX, ovaries related. The reality is that the whole world is actually not that super easy. We really like our binary columns. And so to also mention intersex is when biological or anatomical parts are not perfectly aligned with either internal or external organs. Great job. So the chat is talking about internal and external reproductive organs, genitalia. Again, bonuses for spelling genitals or genitalia correctly. Chromosomes, we already mentioned a little bit about XY or XX are usually the default two we think about, even though there's 500 combinations of chromosomes. Estrogen, testosterone, we usually think about in this binary way. Truth is, most of us have estrogen and testosterone kind of coursing through our bodies, but we like to think of one associated with one sex and one associated with the other sex. What is also really interesting about anatomy and biology is it's pretty much based on assumptions. Socially, it's not a good icebreaker. Just in case you're doing that, drop your pants, let me see your genitalia. Thank you very much, ma'am, for my Starbucks venti latte is not appropriate. So don't do that. So if you are, stop it. When we start talking inside of this binary, the reason why it is socially inappropriate to ask these questions is also an interesting combination. Most of us have no idea what our chromosomal makeup is, what our internal organs look like, or even maybe what our hormones look like, unless we're having puberty, fertility, or menopausal related issues. Then you might know about them. I know when I went locally to get my hysterectomy, I had a great conversation with my doctor, and I was like, I have a very fun job. While you're up in there, can I also get my chromosomes checked, my hormones levels checked? When you take out my ovaries, like, can I see them? This would be fun. Can we do all this stuff? And I basically was told, no, I don't need to know those things. So even though I asked for it, was willing to pay out of pocket and have insurance, I still actually don't know my chromosomal makeup. I think I do. And the truth is, y'all often think you do because of the way that we perceive people. You perceive me as a female, hopefully, and by doing that, you then assume that you know what my internal organs look like, what my external organs look like, what my hormones are, and what my chromosomes are. This is an assumption that we make. So then when we start talking about intersex folks, where that is ambiguous, or at least not perfectly aligned in this socially constructed binary, that's when things can kind of get confusing. You might be more familiar with the word hermaphrodite, which, in case you're interested why no one invites me to parties, is Hermes, the ideal male, and Aphrodite, the ideal female, are of course heterosexual, consensual, and fertile, and have the ideal baby. And the ideal baby was a perfect blending of all things male and female, and they named their baby Hermaphrodite. And that word is rarely used now, although some people still do, to describe someone whose internal or external organs, genitalia, hormones, chromosomes, etc., do not perfectly align. We now use the word intersex, or someone has intersex condition, largely because of the internet. There's a lot more of a visible community around folks who may not be perfectly aligned in this kind of made up binary way. Before we go to gender, though, just noticing anatomy and biology, on this side there's kind of an extra box on the handout, and that is secondary sex characteristics. So based on your genetics, based on your DNA, your body does different things, and then those are also socially interpreted, right? So body hair is a really great example. Some people can partake in No Shave November, because if you stop shaving your face, you will grow a beard. Congratulations. Not everybody can grow a beard, no matter how hard they really want to grow one. You could be like me, where I don't have a lot of visible facial hair, except for one hair that is completely invisible until it is 9 inches long and only visible at a red light occasionally, which is why I have tweezers in my car. I don't want that one hair. I somehow have been predisposed to have the one facial hair. Same thing goes with size, the voice depth or height, how big your feet are, where your body stores fat, the difference between breasts and man boobs, hips, things like this. They're socially interpreted sex-based characteristics that are based on genetics and or your DNA, as well as your hormone levels, which are also usually based on genetics or DNA. So those are secondary sex characteristics that are on kind of this side of the triangle. So before we move on to gender or any other part of the triangle, are there any specific questions about male, female, sex-based words or body parts, anatomy, biology, those kind of things? I just want to pause and see if there's any thoughts, comments, or questions. I don't have any texts, but the texting number again is 202-670-4262, especially for the recording. If you are actually watching this recording, you can also text message me anytime you want, and I'm happy to answer your questions. So I don't see any. Great. So if we have biology and anatomy somehow clear as mud, and we take it and put it on this side of the triangle, this side of the triangle would then be gender. All things gendered. What is incredible is that we gender things that aren't even biological or anatomical, like your car, for example. Gender is usually divided into 4 categories, and it's some combination of those 4 categories. They spell ripe if you are playing along at home. So if you don't forget, it's gender roles, gender identity, gender perception, and gender expression. So we're going to leave the third one, gender perception, off for just a second, and we're going to focus on gender roles, gender identity, and gender expression. So gender roles are how you interact with the relationships with other people, spaces, sounds, your job, etc. We gender those, and whether it's loud or small or big, or there's family roles like I am a sister and a daughter and a wife, and those things become very gendered. Those are the kind of roles that one kind of plays, usually in conjunction with other people. Gender identity is a way of thinking about kind of labeling yourself. So it's like a sticker that you put on, and that's kind of the words you're using to describe yourself. So perhaps that's like masculine, feminine, androgynous, something like that. That's a descriptor of how you identify as an identity. And then gender expression is the outbound messaging of that identity. So we kind of perceive hairstyle and clothes, but as well as those roles and the language we use to describe ourselves, which could be pronouns or names or the way that we describe ourselves or describe other people. They're kind of performative as far as expression goes, as well as the identity or the roles that individual or yourself may hold. So if you have gender roles, gender identity, and gender expression, we had to skip gender perception because that's the one that actually none of us have any control over. We hope that somebody else will validate or verify or advocate for how we identify ourselves. So when we start talking about being an ally or being an advocate, that's what that means, is that you're allowing someone to identify them the way that they want to identify, whether you perceive that to be accurate or not. You're just going to let it stand because that person probably knows themselves better than you. So gender perception is out of your control of how you are perceived, but what you need to perceive other people is in your control. So I like to use the example walking around airports. When people are walking behind me, I will modify my behavior based on who I think is behind me, based on the sounds they are making, right? That's usually the sounds their shoes are making or the voice if they're talking on the phone. And then my behavior adjusts accordingly based on my perception of what I think is behind me. But that doesn't always mean I'm accurate or correct, but my behavior will still kind of modify based on those perceptions. So gender identity is gender roles, gender expression, outbound messaging, gender perception, no control over it, but you do get to like be responsible for what.
Троечка, что ты хочешь? Я не слышу тебя.
Natalia, were you trying to say something to us? No. Okay, great. So gender roles, gender identity, gender perception, gender expression. Those are the kind of 4 pieces of gender. Any thoughts or comments specifically about gender itself? Not seeing anything. I did get a text correcting me about hermaphrodite, which says, was born male, he was a water nymph, fell in love. Since they didn't want to be apart from each other, the gods melded both into one being. Also, plot twist, Hedwig. Also a thing. Any thoughts about gender? Not seeing any. Okay. So similar to how intersex may show up inside the sex side of the triangle, this is also where trans and or gender nonconforming, non-binary, etc. may show up on the gender side of the triangle. And what that generally means is the roles or the identity or the expressions that someone has for themselves do not always align with how they were labeled or raised or the expectations an individual had put upon them. And then once that individual has a sense of agency, they may or may not agree with it. Now, this is an important distinction because if you kind of do agree with it, then that might actually lead to what is often referred to as cisgender privilege. So another reason why people do not invite me to parties is cis, C-I-S, is the Latin prefix that means congruent. So even though I was supposed to be a very different kind of woman raised in Texas, I do still identify as a woman. I do still identify as a female. And even though I identify probably more masculine than my grandmother wanted me to, that's not exactly what her expectations were. I don't identify as a trans person or a non-binary person. So I have cisgender privilege. As a cis woman, you may hear this kind of terminology. How I was raised and how, once I had agency, is pretty much in alignment. That is cisgender privilege. So when we start talking about gender inclusion, it's a really important thing to understand that sex and gender are something all of us have. And some people actually may identify in a way that is different than when they were born, and some people don't. That's really all it is. But the gender side of the triangle is where the T, whether we're talking about the kind of older terminology might be transsexual, which is directly related to changing the anatomy or the biology of one's body. Not everybody was interested or had access to surgeries or medical care, or they were fine with their body. They just don't identify with how they were labeled or perceived. So then transgender started being used around kind of that difference, even though it's not necessarily binary in its own sense. Gender, non-conforming, non-binary are other words that are often used as well that don't fit into that kind of binary expectation. So that would be the gender side of the triangle, and then cis would be the folks that are congruent. So questions or comments specific to the gender side of the triangle that I can help with? thoughts, comments?
I had one question.
Can't wait.
So if we're in the gender part of the triangle, one thing that you said earlier was that one could identify as cis, either woman or man. Well, one thing you said, and I don't know if it was intentional. In your specific example, you said, I identify as a cis woman, or identify as a woman, and I'm cis, which is concurrent with what like I was assigned. I don't think you didn't put it that way, but you also say I identify as a woman, I identify as a female. My point being that that was a crossover into the sex part.
Yes.
Was that intentional or accidental or what?
So I would say it's intentional in the sense that I was labeling different ways that I identify. Sex and gender are often conflated together. I also identify as a white woman. I identify as a white female. Those are different identities that I hold. And when we start talking about how one perceives gender, I perceive gender from all of those spaces. And then people perceive my gender as well as all of those other spaces because they get conflated together. By pulling them apart and spending a little bit of time around sex and a little bit of time around gender, we can talk about them a little separately. But the way our languaging works and our perception of gender, because our perception of sex is usually not something we can do socially. Specifically inside healthcare, we may need to know more sex-based information than a Starbucks barista may need to know. So then they kind of slam back together and get conflated together. So I intentionally did it as we are moving around the triangle. Other thoughts, comments, or does that need a follow-up? Was that clear? The room labeled lounge that I referenced earlier as Slytherin, you made a hand gesture, but I couldn't see what it was because the picture's too small.
Thumbs up.
Thumbs up. Okay, great. I will take all thumbs up. Okay, so to review, if sex is biology and anatomical parts that we don't actually always know about strangers in the grocery store, and gender is very much outbound expressions that are often perceived by other people, and we are responsible for the information we need to justify our own perceptions, but we have no control over them. To round out the triangle, we get to sexual identity or sexual orientation. What is interesting to me about sexual identity and sexual orientation is that when sex and gender get conflated together, it is through our identities and or expectations of other people when we are coming up with language to describe the relationships we want to be in or are in or don't want to be in. Those words are related to our sexual identity or sexual orientation, which then also snap into this mysterious need for a binary choice. So for example, if we are talking about a heterosexual couple, it is assumed that the quote-unquote man of a heterosexual couple is also the masculine person and is also the male person, and that their gender roles, their gender identity, and their gender expression are going to be in alignment with all of the expectations of what we also assume their body looks like, and that then generally would make them a straight person. If that person were to come out as gay, then all of the sudden we assume that their gender becomes far more feminine, which is why masculine gay men don't have as much of a visibility, let alone gender nonconforming or non-binary gay people. When we talk about lesbians, the exact same thing happens. If we're talking about a heterosexual woman, we assume that woman is feminine. We assume what her body looks like, which we assume is going to be everything in the column of female. So then this female who is feminine and a woman who's going to be assumed to be heterosexual unless we find out otherwise. And when we find out otherwise, we assume that they are then a lesbian, which would then make them masculine, which is why feminine lesbians may have less visibility, or non-binary, gender non-conforming people who identify as lesbians would have less visibility, because we kind of smush it together automatically into this binary that makes people more comfortable. When we start talking about bisexual, pansexual, omnisexual, fluid, demisexual, etc. These are words that are being used to further describe what kind of relationship someone wants to be in, what kind of sex someone wants to be having or doesn't want to be having. And those words often, I make a joke, probably inappropriately, that they have to come with a pamphlet, because what ends up happening again with the binary is you're either straight or you're not. And if you're not, then you're either gay or lesbian. And if those are not the appropriate terms someone uses to identify themselves, then they have to kind of explain it or get comfortable with being shoved into kind of a square peg round hole that makes someone else comfortable within a binary, because then they can round out the rest of the triangle, because they know what feminine looks like, they think, they know what masculine looks like, they think, and they know what male and female looks like, they think. So then they're better somehow, but that's not necessarily reality. So part of the motivation of the SOGI questions in general was to be able to talk to a patient and or their guardians or parents or possibly even their partners, depending on what kind of appointment it is, to have a conversation about sexual identity or sexual orientation, a gender identity, the language they use to describe themselves, and how that intersects with providing long-term health care for that particular patient. So it's important when talking about sexual identity and sexual orientation, heterosexual and straight, gay, lesbian, bisexual, queer, pansexual, omnisexual, demisexual, asexual, possibly even questioning. There's always new words being created to define who one is and who one isn't when we start talking about someone's sexual identity or sexual orientation, which is actually not dependent on gender or sex, but they get smushed all together. And they usually get smushed together around that ally advocacy perception door as that kind of enters into the triangle. So if that's sexual orientation and sexual identity, generally speaking, and obviously I'm doing this relatively quickly, are there any thoughts or comments about the labels we use to describe our relationships or the relationships we're not in, separate from sex and gender and how those are perceived? Any questions about sexual identity or sexual orientation? Again, the texting number is 202-670-4262. If you have any questions you'd rather text, then say out loud.
Can I ask about someone who might be asexual?
Yep.
Can you expand on that? And,
Sure.
and I guess like gender identity in that regard, or?
Sure. So again, gender identity and anatomical biological sex are separate things. So if someone identifies as asexual, they may or may not be interested in an emotional or physical or sexual relationship with someone else. A lot of people have their own kind of definitions of generally those three categories. I'm generalizing, but generally speaking, an asexual person is not waiting or looking for a particular kind of emotional, spiritual, or sexual relationship. They're able to have friendships. They can possibly be like, have intimate relationships with people. They're functioning people in society. That's just not something they're necessarily interested in. And what ends up happening is very similar to gay and lesbian folks when they meet straight people, and straight people say like, oh, you just haven't met the right woman or the right man yet, because they don't believe being gay or lesbian is a real identity. Heaven forbid you're bisexual or fluid. Gay, lesbian, and straight people don't always believe that's a real identity. When an asexual person intersects a straight person, or if I use queer as an umbrella term, often they get exactly the same thing. Well, you just haven't actually met the right person. Or like, maybe you're just not very good at masturbating. It's not seen as a real identity because other people don't understand it because it doesn't always fit into a binary. So an asexual person may or may not actually need health care related to having sex, and they also still have orifices and body parts. I remember 100 years ago when I did this similar training at the dental center in Open Door, they were like, well, we don't have anything to do with sex, so we don't have to talk about this. Because they at the time, didn't understand why they had to ask the SOGI questions. And I was like, I don't want to disclose too much about one's sex life, but you are dealing with people's mouths. Mouths can be involved in sex, so you do need to have a conversation with a patient about what they may or may not be doing with their mouth if the goal is long-term health care. Oh, I didn't think about that, right? So that's why the questions exist, so that you can have an ongoing conversation with your actual patient about what it is they actually need. Because it's also important to mention that identities are not, oh, I always do this wrong. They're not static, right? Is that what I'm trying to say? Because they actually can move and change. Static means stationary. Is that right? Am I doing it backwards?
I think you're doing it right.
I think I'm doing it right. Okay, great. It's been a day. So, because they can evolve and change over time, then that's part of the reason that you should be asking these questions. Now, we all know that when you work with patients, some patients don't know what information is important to disclose. And so then your job is to kind of pull out the relevant information. But it is also the case that as a medical professional, you often can make judgments and assumptions about what they are or are not saying based on your own experiences. So you have to kind of close the gap through curiosity by actually asking questions and working with the answers that are given to you, which may lead to a different question. There's a question in the chat. We'd like to know what you mean by fluid. Fluid sometimes is used as an identity instead of bisexual, because bisexual, again, very binary, is that there are only two options, and whether someone recognizes that there's a much broader spectrum of gender identity or gender expression or gender roles that someone might be attracted to. Some people use the word fluid to describe their attraction to different people. Some people, like I'll use myself as an example, I am attracted to exactly the same human being, generally speaking, if they were lined up, right? Like somebody reading Kafka at a party wearing Pumas, I'm going to be attracted to them. Or at least I was in college. So that just is going to happen. So like your type, some people use that language. When someone is trying to find out what your type is or what team you're on, they're usually trying to place you inside of a binary. So identifying as fluid was more popular a while ago. Maybe it's still popular now. I'm old. But it was used to specifically talk about the fluidity that people sometimes are more comfortable attributing to bisexuality without having to be limited to only two options. That's what I meant by fluid. All right. Other thoughts or comments? Great questions. Keep them coming.
I do have a comment for everyone. Is that I think that there was a little talk before where we asked the patients what they call their body parts.
Mm-hmm.
So my patient, who is a female to male transgender, referred to their clitoris, who has now been treated with testosterone and is enlarged as a penis, not as a clitoris. So this is something that I think we should be acknowledging, because during like a PAP, my patient's crying because I keep saying vagina, vagina, and I didn't know their words. And making sure to acknowledge that, we ask them what kind of words they use to describe their body.
Absolutely. And it's also important to acknowledge that those words may change and evolve as well as people are dealing with their own identities and becoming familiar with their own sense of expression and what words apply to them. That can change over time, especially when we start talking about changes that happen with hormone replacement therapies or hormone gender affirming therapies. Or any kind of surgery someone might be having, the language may change and evolve. And the idea, much like pronouns or preferred names, etc., is to use what they are using to describe themselves. But what ends up happening, again, because of the power of perception, is that often we engage in these conversations with the expectation that we know everything. So then the person has to correct us, and then we often get defensive because we actually thought we knew everything. But we just got told that we didn't know everything, instead of just entering like, I may not know something. So I like to use the example. So we've already established that I'm a cisgender woman. So I've had a complete hysterectomy. So when I go to a doctor and it's fun because y'all are local, right? So my family practitioner, my main doctor, primary care person, whatever the language is, there's some new system that has happened in the hospital yet again. So I just went in for a physical, and the immediate question was, when is the last time I menstruated? So I am a smartass. So I said, 11 years ago. And the person who was doing my questionnaire was like, oh my gosh, well, we have to look into this. And I was like, nope, I pretty much paid money for that. Like, we're good. That's fine. So then the next question was, am I pregnant? Definitely not pregnant. Haven't had sex with sperm in at least 30 years. So unless Jesus is getting a sibling, we're probably good on that one too, right? So then again, this poor PA is like, I'm just trying to type my notes, but I have all these answers. And it can evolve and change, but just because it's in an electronic medical record doesn't mean it transfers over, or it may not actually be kind of the same information that someone's having. Plus, not everyone is in a monogamous relationship. So even if you understand the primary partner, that can change, and you can have polyamorous relationships, non-monogamous relationships, or no relationships at all. Those things can happen too. So that's why it's really important to have the conversation and follow along, because unintentionally you could actually be, one, traumatizing or re-traumatizing someone. And again, if the goal is long-term health care, then the last thing you want to do is create more trauma that prevents somebody getting health care. So, great example, Nicole. Other thoughts or comments?
I'm going to make another comment. I'm sorry. There was a patient case where she had expressed to her doctor that she had cheated on her husband, and that was documented in the charts. Later on, she communicated to a different doctor that she wanted that part of her history taken out. And so I guess in terms of documentation as physicians, how much should we be doing, not doing in this case? Because that can increase your chance of, because of that piece of history, but the patient themselves is requesting that to be taken out. I guess I struggle with how to take care of someone long-term, but that I can't have this piece of information in their chart. And I don't want to ruin the patient-physician relationship.
Sure. So I first would throw out, I was a ceramics major. So with that, let me give you some advice. With the advice, the goal is long-term healthcare. So finding out that someone cheated on their husband, first off, is fairly subjective, because it's possible that that was a summary of the disclosure, and so it was assumed that they cheated on their husband. Maybe it was consensual. Maybe they're in a non-monogamous relationship. So the way that we kind of judge the information that is disclosed shows up in subjective notes. So then if the client, or in this case, the patient says, I'd like that removed, you don't know why they want it removed. And my question would be, why do you need to know that information? And if that information is actually related to healthcare, or that information is related to, notice the air quotes, character is not what you are treating, right? Like you're actually treating a physical body. So it might be more important to know that they are sexually active. And then what does sexually active mean for them? Sexually active for some people is sitting on the couch watching Hallmark movies. That's not even exchanging body fluids unless we count tears, right? Because of Hallmark movies. So what information do you actually need to know versus what information do you think you need to know? So when I work with healthcare providers, I like to put on your IRS hat. So in the IRS, or credit reports, you can run your credit report and you can look and see what's there. And if you don't like something on your credit report, they can actually put a note into your credit report that explains something that's there, and it's expunged after 7 years. For medical care, what's interesting is that we really need to know all this information much longer than 7 years, because it's not taxes. So then, for example, when my parents died when I was a kid, I'm almost 50. I told you, good skin. So I'm almost 50, and I'm now at the place where I have to fill out all these questionnaires about like how long my mother lived, how long my father lived, all this information about them. I was 19 when they died. I have no idea. I did not have these conversations with them. But whatever rubrics, boop, 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 that's med school to me, right? Is that you get this information and it goes boop, 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 boop through your expertise. That somehow means I should get a colonoscopy this year. Okay, I'm sure. I was in the Peace Corps, happy to do that again. But I don't know what the connection is to my parents, because I have no idea if my parents got colonoscopies. I'm assuming my parents had colons, but I actually don't even know that information, right? So a lot of the information that we are using, I think, is kind of a checks and balance for the decisions that you are making. But not everybody fits into those checks and balances. And if the goal is long-term health care, then you actually get to this is what the notes section is for. So you get to actually engage with a real human being about how they are doing and what's going on with them. In this particular case, this same doctor's appointment, she was really nervous to tell me that I am at an age where I should probably go get a colonoscopy. And she didn't know, because I was in the Peace Corps, this is like my 20th colonoscopy. Sounds great. Knock it out. I don't care. I love barium. Yum. And it's probably some new thing you drink now anyway because of technology. She was nervous about telling me, so I'm taking care of her while I'm just receiving basic health care. These are humans. You're going to bump into them at ENF. Like, can you remember that they are humans when you're in such a small place, right? And part of what I love about community health centers is like that actually should be a hell of a lot easier for you than in a bigger place. So I technically have 3 minutes left, so I want to get inside the triangle, but I want to make sure that we have questions. Somebody put into the chat, it documents their risk of having multiple partners. Oh, why? Okay, but if you're documenting they cheated on their partner, then say that they have multiple sex partners. But in order to say they have multiple sex partners, you also need to know, are they still having sex with their primary partner? If they're not having sex with their primary partner, they're not having sex with multiple partners. They're having sex with a different person than the person who would pay the bill if they don't pay the bill. Right? So again, you have to have those conversations about what does that mean. And just because you're having sex with multiple people doesn't mean that it's risky sex. And what do we mean by sex? Right? Like, people could just be masturbating with each other. People could be doing all kinds of behaviors. But those are the kind of conversations you need to be having. And to have those conversations, it's a little harder when you've made assumptions about their anatomy and biology, and you're making assumptions about their gender identity, and you're making assumptions about their sexual orientation and the relationship or agreement they have if they have primary partners or just dating or something. Those are conversations you need to have. So I'm going to move inside the triangle. Does that sound okay? It sounds like some kind of strategic situation. So between sex and gender at the top of the triangle, there is an oppressive force that polices what we call sex and what we call gender. The oppressive force ends in ism. If anybody wants to guess what it is, because we're short on time, I'm just going to tell you. It's sexism. So if we were to talk about a sexist society, like how about the United States? What we would mean is the most unicorn points go to masculine male men. I do not mean mail carriers, although some masculine male men may also work for the Postal Service. But when I say masculine male men, I mean cisgender men who identify or are perceived in a masculine way. Because we live in a patriarchal society, they have more unicorn points. Everybody else has less. But cisgender feminine female women, who may also work for the Postal Service, just to be confusing, when we start talking about feminine female women, cisgender women who are feminine, they also have a lot of power and privilege because they are part of that binary. They're successfully perceived the way they are wanting to be perceived, and it fits nicely in this little binary for everyone else. I say that specifically because a lot of times what happens is that cisgender women look to cisgender men at all the privileges they have that they don't have, but they don't take responsibility for the privileges they have of gender nonconforming, non-binary trans folks, or feminine men, masculine women, etc. So there's some responsibility there that needs to happen that is also part of sexism. We can, different workshop is whether we're talking about internalized oppression, externalized oppression. We can do that again and later if you want, but that's how sexism shows up, and it polices our perceptions of sex and gender. If we go down the triangle, heterosexism is the oppressive force that polices the conflation of sex and gender and sexual identity or sexual orientation. This is heterosexism, which is why we assume everyone is heterosexual. We also assume that everyone is monogamous and is only looking for one partner for life because that's how hearts work. But in those assumptions, heterosexism is what polices what is heterosexual and what isn't. And I would challenge that if you are gay or lesbian, similar to women, if you're gay or lesbian, you have some power and privilege because fluid, demisexual, asexual, bisexual, queer folks usually are not seen as solid identities, whereas gay and lesbian are. So if you identify as gay and lesbian, I would suggest we kind of collaborate around the privilege of what it means when other people know what our words mean, And heterosexual folks, you already know that that's how heterosexual privilege tends to show up. So that is the general overview of the question of sex, gender, sexual identity, or sexual orientation, and with a model that was used when the original SOGI questions were developed and the training associated with the SOGI questions were implemented as people started using them as part of the patient experience. Thoughts, comments, anything else I can help with? Dr. Is it Kashani? Is that correct? So I'm saying Nicole because I have the audacity
Yeah,
to
it's
call
fine.
them by their first name. You're getting props in the chat. I wanted to make sure that you saw that.
I
There are
did.
great questions and examples.
I think it's a very touchy subject. I think walking on eggshells sometimes, and it takes away from the patient encounter sometimes, which is a challenge. I feel like if there is a patient who I can't identify with, I have a cognitive bias that maybe I'm not doing a better job.
Mm-hmm.
with
Sure.
them.
And what I would challenge you is every patient you have, regardless of sexual orientation, gender, relationship status, etc., every patient you have has some tidbit of medical history that would have been super helpful if you had known it in advance. But you didn't know it in advance and you still had to make a guess.
Mhm.
So then part of your job is making a guess. What is fascinating about SOGI is that we're telling you you do not have to guess. Literally based on state law in California, you are supposed to ask. So then the bonus there is that there is no guessing. What the guessing you do have to do, if any, is did the patient answer you completely? Or did the answer that the patient gave you leave out some information because they're also testing you and how much they can tell you? Right? Some patients also, this is new language for them. So then you might have to do some education for them so that they can answer the questions accurately. And these things are all moving parts, so then other pieces kind of change.
Do you have a link to the SOGI questionnaire that you can put in the chat?
I don't, but I bet somebody
Okay.
does.
Okay.
Yeah. Perfect.
That is all that I'm done talking.
Well, again, please feel free to text message 202-670, 202-670-4262. I forgot the number. Because hopefully this is relatively thought-provoking. That is my job. And if you have questions later, I want you to be able to ask them when you have them or when you're in a particular situation. Okay, so this just happened. What am I supposed to do? I would like to let you know that sometimes what happens is like we have read a book, we watched a movie, like I get it, I know everything. And then you meet someone that doesn't fit perfectly into the thing that you know. You don't have to throw everything away. You're just going to have, watch what I do here, a patient experience with that patient experience. Do you see what I did there? Best example I can think of is all of my vegan friends that eat bacon. Excuse me, by definition, you're not supposed to eat bacon. If a vegan is going to make a meat choice, I stand behind bacon being the choice. I get it. I understand. They're able to be a vegan however they want to be a vegan, and your job is to figure it out. And if you can't figure it out, you should be asking questions and honor whatever it is they want to do. You don't tell them, excuse me, that's not the definition of a vegan. That's their definition of a vegan, and they're making wise choices as far as I'm concerned.
Probably the far more important thing is, hey, what do you like to eat? Or, hey, what do you like to identify as? Probably better. I don't know. Another comment that I would have is testicles, penis, uterus, ovaries, something in between. If when you pee, it doesn't hurt, it's probably perfectly fine. And then the other one would be male, female, or I'm sorry, man, woman, cis, trans, person. All of them are persons would be another thing. But that is me, pronouns he, him, cis male, or cis man coming from my place of privilege in the patriarchy.
Yeah, and to possibly end on kind of like a simultaneity intersectional theory bent, It's also really important to mention that when, I don't think you were doing this, but I want to just throw this out there, that when we grasp for all the similarities, we're also really minimizing the experience of difference. So where like we're all people, right? And I mean, medically, it seems like a pretty good go. If you can pee without it hurting, all good. But if you're going to have long-term patient care, I probably might need to know, is there a chance it could hurt? Is there a chance that like hair is going to grow in an internal way that's going to screw up your ability to pee?
You could
Because
also
of, like,
say, is there a cervix that could get cancer?
right. And so
That
when
could,
I,
you
like,
know,
if I tell you, no, I do not have a cervix, I shouldn't have to then explain where my cervix is. I'm telling you, I don't have one. Super promise. I tried to keep it home in a jar, and evidently that was gross. So there's trusting your patient, and there's also acknowledging that some of the things you may be doing, just check yourself, right? You may be doing something to make yourself more comfortable, and that's not about the patient. And so you don't want to minimize the fact that some people have very different healthcare needs. When my husband and I both got his and her hysterectomies at St. Joe's at the time, they were both pre-approved by insurance. And then after we both got a hysterectomy, I had to justify why there were two hysterectomies in an MF marriage. That didn't make any sense. You're MF. So I was told that straight people don't have two hysterectomies. And I was like, okay, well then call us both lesbians. Well, I can't call you lesbians because I can't cover, this was insurance before gay marriage was legal. I can't call you both lesbians because then the benefits would change. And I'm like, okay, we have had hysterectomies. Do you want our money? That's where we're at. So, and then the last thing I'll say, because I know we're over, is also when we get to like billing and insurance paperwork, there's almost always this stupefaction of like, woo, they don't check this box. That's going to be hard. Tell them. You don't have to triangulate against the patient, triangulate with the patient. The goal is long-term patient care, and say, this is a dumb form. And in order to do this, if you check this box, insurance is going to pay for it. If you check this box, insurance is not going to pay for it. What would you like to do? Like, you can explain to them and then give them agency to do what they want to do, because you're on their side, you're not against them. Specifically, this goes back to that minimization thing, and then I will shut up maybe. But the other thing that's really important is that, especially when someone has an oppressed, marginalized, or subordinated identity or experience, they're expecting you to not get it. So the ally bar is very low. Very, very low, because they're assuming that you're not going to get this. So even if you kind of attempt to get it, think about when you're kind of muddling through a second or third language that isn't really what you do. People become very patient with grammar mistakes because they see that you are trying to use a language that is obviously not your native language. The ally bar is very, very low. The goal is long-term healthcare, not showing that you are correct. So without minimizing someone down to like, all patients have this. But the SOGI question should be asked of all patients, because all patients have a sexual orientation and a gender identity. That's why you're asking everyone. You're not asking everyone so that the non-binary or trans people get to talk. Everyone has one of these, and you have one of these. So then be part of the conversation. You'll be part of the patient experience. So that is what I got for today. Again, the texting number is 202-670-4262. If you're watching the recording, you are totally welcome to text message me. If you are here in real time, you are welcome to text message me when you are making dinner and you're like, wait a minute, I got to ask a question. Just text message me. I'm happy to answer. So thank you very much. Thank you for dealing with me being a little late. It has been a day. And I really appreciate, my favorite thing is my job, and getting to do my job after a crazy day is perfect.
Thank you.
More than welcome.